Good morning, everyone. I'll be presenting on behalf of Medicine 5. The topic for my presentation is titled A New Mask on an Old Face. Presenting Mr. D, a 23-year-old, who had presented with one episode of hematuria 10 days back. He had periorbital puffiness for 10 days, pedal edema for 10 days, and he also had nausea and vomiting and constipation. So he was well till the first week of January when he developed one episode of a cola-colored urine. Subsequently, he developed multiple episodes of vomiting, 2 to 3 episodes per day, which was non-projectile, non-bloodstained, and non-bilious. He also noticed puffiness of the face as well as pedal edema. He does not give a history of decreased urine output. There's no history of skin infection, throat pain, or fever preceding this. There's no history of headache. There's no history of renal stones or dysuria. No joint pain, renal abdominal rash, hemoptysis, or oral ulcers. No history of altered sensorium or focal deficits. But his family noticed that he was responding to questions very slowly and was very lethargic. No history of any alternate medication intake, no history of NSAID use. He had gone to Chittor Hospital and was found to have a creatinine of 7.73 and was referred to CMC for further evaluation. So when he initially came, his pulse was 88, the blood pressure was 100 by 60. He also had pallor. There was no icterus or cyanosis. There was bilateral minimal pitting pedal edema. He also had periorbital puffiness, and there was generalized ichthyosis over his lower limbs. There was no elevated JVP, there was no markers of vasculitis. Systemic examination was normal, and abdomen was soft and non-tender. Liver and spleen was not palpable. There was no renal angle tenderness. So these pictures have been obtained with permission. You can see the periorbital puffiness in the first picture and generalized ichthyosis in the second picture, along with pedal edema. Bedside, his urine had shown frank hematuria. His hemoglobin was 8.3, his WBC was 6,500, platelet was 51,000. His creatinine in CMC was 6.37, and liver function test showed a mild transaminase elevation. He also had hyponatremia at presentation. His urine showed RBCs of 402 per HiPAF field, WBCs of 20, and blood 3 plus protein 2 plus. There was presence of bacteria, but nitrites were negative. So in this gentleman, he's presented with a rapidly progressive renal failure. So the differentials we considered were renal causes as bar systemic causes. In renal, primary glomerular causes like a post-infective GN or an IgA nephropathy, tubular interstitial diseases, or vascular causes were considered. Systemic causes like systemic vasculitis like ANCA-associated SLE, because he had anemia and thrombocytopenia, even hemolytic uremic syndrome was considered, and any occult infections. In this patient, there was no history of any drug intake. His 24-hour urine protein was 1708 milligram per 24 hours. We had done an ultrasound abdomen to rule out any post-obstructive causes, which showed only grade 1 renal parenchymal changes, and it also showed internal echoes in the bladder, looking like a cystitis. So we sent off a urine culture at this point. Renal Doppler ruled out a renal vein thrombus. Because he had anemia and thrombocytopenia, we had looked for schistocyte, which was nil. LDH was elevated. We had suspected a post-infectious glomerulonephritis. However, C3 levels were normal and ASO level was normal. Because it was not complement fixing, we went ahead with a vasculitic workup. ANCA, PANCAs were normal, and ANA was also negative. In the ward, by day 2 to day 3 of admission, the patient started developing low-grade fever. The fever was around 100, and patient also complained of chills at this point of time. So we sent off blood cultures. And by day 3 to day 4 of hospital admission, we noticed that the patient was developing a rash over his upper limbs as well as the abdomen. It was a faint erythematous rash, which was blanching. This rash subsided within 2 days. At this point of time, can anyone guess what this could be? Okay, I'll just give a clue. So the blood culture for this patient grew Salmonella typhi, and interestingly, even the urine culture had grown Salmonella typhi. The peculiarities in this patient is enteric fever is classically described as high-grade fever with chills and loose stools, but actually 30% of adults do present with constipation, 50% present with diarrhea. And second thing, whether this patient had a glomerular, he presented with an acute nephritic syndrome. He had frank hematuria. However, there was no hypertension, and the oligurar history was query. Typhoid, renal involvement of typhoid has been described as early as 1938 by Reba, wherein his patient also had urine culture growing Salmonella typhi. And in that article, they have actually shown how the Salmonella goes from the intestine to the kidneys via lymphatics. Also, there is a hematogenous spread. So renal involvement in enteric fever occurs only in 2 to 3% cases. And what are the manifestations? They can have a cystitis, a pyelonephritis. There can be a mild proteinuria or microscopic hematuria. Patients can have an acute interstitial nephritis. Because of the dehydration, they can develop an acute tubular necrosis. There has been one case report of acute renal failure secondary to a rhabdomyolysis. And other cases have been described where there was a coexistent IgA nephropathy, a hemolytic uremic syndrome, as well as a HSP associated. And there are a few case reports of glomerular nephritis. I'll just highlight a few case reports. There's an 11-year-old male who had come with a fever and hematuria. His blood pressures were high, 132. This patient presented with a serum creatinine of 7.1, and his 24-hour urine protein was 1.21 gram. His urine culture was sterile. However, blood culture grew Salmonella typhi and viral was positive. They had done a renal biopsy in this patient, which actually showed features of a diffuse proliferative glomerulonephritis. There was increased mesangial cellularity, and there was extensive infiltration of the neutrophils within the glomerulus. However, there was immunofluorescence showed no deposits in this patient. He received 2 weeks of hemodialysis, and subsequently creat came to normal within 4 weeks, and proteinuria resolved completely after 1 year. It's another patient, a 13-year-old, who had again presented fever, abdominal pain, loose stools, and hematuria. He had come with a normal creat. Serum creat was only 0.7. However, he had 3+ proteinuria with microscopic hematuria. In this patient, the C3 levels were low. So what did his renal biopsy show? It also showed enlarged mesangium, but you can see here that the immunofluorescence picked up C3 deposits along the glomerular basement membrane. So he was diagnosed with membranoproliferative glomerulonephritis with a dense deposit disease. This patient received 2 weeks of ceftriaxone, and the entire renal parameters normalized within 2 weeks. The third case is a 10-year-old male who had come with fever, diarrhea, and he presented only Panasarca. He had facial puffiness, ascites, and bilateral pedal edema. He had a 24-hour urine protein of 2.184 grams per day. In that hospital, they had treated him with methylprednisolone and captopril. You can see within 2 months that the proteinuria has completely resolved, and even the microscopic hematuria has resolved. Initially, he had 2.1 grams of protein, and now it is only 100 milligrams of protein in the urine. So typhoid involves the kidneys by 2 things. Either there is an immune complex deposit where there is IgA and C3 deposition in the mesangium, or it's a direct toxin-induced nephropathy where the Salmonella typhi VI antigen is seen in the mesangial area and can directly affect the podocytes, causing proteinuria. So what happened to our patient? He was started on azithromycin 1 gram per oral once daily. His urine routine has showed marked improvement. Initially, there was 450 RBCs, which has now come down to 108. And WBCs also have come to 4 to 5 per hyper field. His creatinine admission was 6.37, and right now it was 1.76. Our patient, when he presented initially, he had severe lethargy, and he also had hyponatremia and generalized ichthyosis. We had suspected the hypothyroidism with center TSH, which was markedly elevated, and he also had low T4 and FTC. Thyroid peroxidase antibody was positive, and he's been started on L-troxin supplementation, following which the patient has shown marked clinical improvement. So our diagnosis is that of an enteric fever with a urinary tract infection. The causes of his acute kidney injury could either be pre-renal cause or a possible acute tubular injury secondary to hematuria or a glomerulonephritis. He possibly has an underlying chronic renal disease. And he also has severe hypothyroidism, Hashimoto's thyroiditis. The learning points from our cases, the renal involvement in enteric fever, and interesting to note that the typhoid-associated GN occurs during the active stage of the disease, as opposed to a post-streptococcal, which has a remote history of fever. And the third thing is how a typhoid can cause glomerulonephritis.
Very interesting case, Reba. The very rare presentation of typhoid. In my own experience, I've actually seen very few cases which have had renal failure of this degree requiring dialysis. And this was particularly seen in the period we used to see a lot of typhoid. And this patient has actually presented with a feature like an RPGN with frank hematuria. Now, here, we don't know what the pathology is, right? But what we do know is that it's rapidly improved. So do you think, you mentioned toxin and you mentioned that it could be an immune-mediated mechanism. Do you think that the Salmonella typhi itself, because it was there in the urine, it's actually a nephritis due to Salmonella typhi, which is causing the renal failure? I say this because the renal failure rapidly improved. It was not behaving like a glomerular nephritis. It was, as you pointed out, in the stage of bacteremia, where there is involvement, there is bacteria in the urine, that you're seeing the renal failure. It's something to think about in this patient. Any other comments from the audience on this case? Any other experiences of patients with salmonella typhi? We don't know whether he has a underlying renal disease. The rapid resolution suggests that it's predominantly due to the salmonella typhi. We'll have to follow him up to actually know whether there is an underlying renal disease or not. I'm going to close the meeting because we're running out of time. We've had 4 very interesting case presentations. We've had Renju presenting about the acute phenytoin toxicity in the setting of seizure, emphasizing the importance of the dosing of phenytoin. And when a patient comes with ataxia with seizure, always think of phenytoin toxicity and do not give any further phenytoin. The Rizwana presented on how they had to sort out whether this was primarily an ALF or whether it was actually an encephalitis due to dengue. And this was a patient who had a primarily neurological involvement, but which had a good recovery. We've had the last case of Reba presenting a very rare case of a patient who's come with a picture like an RPGN who actually had severe typhoid. And the first case, which was a case of Lennart's lymphoma, which emphasizes the importance of pursuing the diagnosis of a patient with suspected lymphoma, because even a negative lymph node does not rule out the diagnosis. Each of these cases have been interesting, and I think I'm going to give the prize to our youngest presenter, Rizwana. All the presentations are suited, but I think I would encourage the youngest person. Thank you. Soumya, would you like to speak up?
I think I was just answering to the rare presentations of Entric. Entric never fails to actually impress us with all of its presentations. We've seen them come in like a MODS. We've seen it with a HLH, but I've also not seen nephritis, as Sir pointed out. So I think that's an interesting vision. And I'd like to congratulate the presenters, and I think everybody's tried to make it quite systematic, the presentation, and stuck to time. I just wanted to appreciate that. Thank you so much.
Thank you to all the presenters. We'll move the other 2 presentations to the next week and we'll close the session.